If we did have to give chemo, what if we didn't know PD-L1 status and they're rapidly progressing? What chemotherapy would you choose?
I would still probably go with gemcitabine and carboplatin. The carboplatin's renally dosed, so whatever creatinine they come in with that day, you calculate their creatinine clearance and you find your carboplatin dose. So I still think that a gemcitabine-based, platinum-based combination in that setting would be my first line go-to.
Yeah, definitely. If truly cis-ineligible, I'll throw in just one other caveat with this case is that the sort of labeling of this patient of cisplatin ineligible is based on a calculated and estimated creatinine clearance. If this patient had ureteral obstruction, I would send them to Gordon for perhaps a stent placement to try to optimize renal function. And typically, I will try to get a 24-hour urine creatinine clearance to really be sure a patient is cisplatin ineligible before making these decisions. As I'm sure we can all comment on, cisplatin-eligible patients have a whole other realm of therapy available to them. We use dose-dense MVAC. There's also gemcitabine and cisplatin. And I think for the first-line treatment, those are still standard of care for patients who can get cisplatin.
So Gordon puts a stent in, creatinine clearance goes up to 47. And we get Betsy's 24-hour urine, and she feels confident it's at least 47. Would you give split dose cisplatin or would you give carboplatin?
So 47 is a tricky number. I wish you had picked 50 because that's sort of our institutional threshold, especially on a 24-hour urine, right? Which typically you typically get more points with the 24-hour urine than you would with the estimated. So assuming this patient, Cockcroft is 42, let's say we get him to 50, I would definitely give platinum with split dose. And there are different ways to give the split dosing. NCCN guidelines has some chemo order sets and recommendations around that. But that just really allows you to give the platinum over 2 days, the same amount of hydration, really protect the kidneys. And we've had success with that. That would be my approach in that setting.
It is something we've done at MD Anderson. We will use split dose cisplatin down to a GFR of 40 mils per minute. And again, you have to be selective in your patients. You can't really give this in a patient with a diabetic nephropathy. Those are the patients whose kidney functions won't handle it. If the kidney is obstructed, you have to unobstruct the kidney with either a stent or a nephrostomy tube is my preference because it does seem to do a better job of improving kidney function. But we've seen some data from InVigor 130 about chemo plus immunotherapy. And will this be a game changer? Will it start changing people's approaches who prefer cisplatin at split doses over carboplatin? I'd be curious what you think about the chemo plus IO group of patients. So we'll start with Betsy.
The InVigor 130 trial is a randomized phase 3 trial conducted internationally. There were 3 arms. Arm A was atezolizumab plus chemotherapy. The chemotherapy was gemcitabine plus either carboplatin or cisplatin. Arm B was atezo monotherapy, and Arm C was placebo plus that same chemotherapy. One important piece in understanding these data are that cisplatin eligible and ineligible patients were enrolled, and the decision of whether to give carbo or cisplatin was a separate differentiator. So patients who were eligible for cisplatin didn't always get it. Sometimes they were given carbo. The reverse was generally not true. It's important in interpreting these data. The baseline characteristics are typical of the patient population we see. And the endpoint for progression-free survival in the intent to treat arm, comparing Arm A, which is atezo plus the chemotherapy, versus Arm C, which is placebo plus chemotherapy, showed a progression-free survival advantage of 8.2 months for the atezo plus chemo arm versus 6.3 months for the chemotherapy alone arm. There are overall survival data as well. And comparisons were made between all of the different arms, which we can sort of talk about later. But I think these data suggest that perhaps we should be thinking about combining atezolizumab with chemotherapy in the frontline setting. The key questions I think that these data raise but don't answer are what to do with a cis-eligible patient versus cisplatin ineligible patient. We know carboplatin and cisplatin aren't the same, right? And so when we're adding atezolizumab, does that same benefit the cis-eligible group as the cisplatin ineligible group, or is it limited to one or the other? They did do a forest plot, which suggests that more of the benefit is seen in the patients who get cisplatin. Again, different from eligible or ineligible. But very interesting data, in my mind, don't quite change practice for this particular patient in your clinic right now.
Yeah. So looking at the trial where I think they said upwards of nearly half of patients who were cisplatin eligible actually got carboplatin, or it was a relatively high number. How confident do you feel in that forest plot? Do you think there could be a little bit of cherry picking going on in the cis arm, or do you think we're seeing a real difference in a cisplatin IO versus carboplatin? I guess we haven't seen much, but what do you think?
Yeah, Arlene, I think when we're looking at this data, about 52%, as you mentioned, of the cisplatin eligible patients actually got carboplatin. Would those patients have done better overall? Would their progression-free survival been longer had they received cisplatin? So that's a key question that I think we're all emphasizing. What I like about the data, though, is that in that atezolizumab plus chemotherapy arm, there were 13% of patients actually achieved a complete response, which is very nice to see. I think what we're seeing is an early rescue of stabilizing disease with the chemotherapy effect, and then as we get on into sort of the later parts of the study where atezolizumab is given as maintenance, we're seeing that durable effect of treatment. And so perhaps the combination in a subset of patients may be beneficial to rescue sort of these early progressors, people who won't get onto a second-line therapy if they fail first line. But in a disease setting where unfortunately we don't have a lot of refractory lines of treatment options for these patients, I'm hesitant currently to use all of my active agents up front in a combination like this unless we see overall survival benefit later on.
Okay. So it sounds like you're waiting until you see an overall survival benefit before you change your clinical practice. How about you, Betsy?
I absolutely agree. Again, if you're using two agents up front that you would normally use sequentially, there has to be a signal in overall survival. Otherwise, it's better to use them sequentially. Cost effective in terms of side effects, it kind of condenses those. So I agree.
Do you think there could be any reason why giving chemo with immunotherapy would be less beneficial? Do you think the chemotherapy could be impacting the immune response, and what we're actually seeing is the impact of maintenance treatment with immunotherapy?
I'm really glad you asked that question. I think, it's hard for us to ever think that more would be not as good as a single agent. It just doesn't, it's not logical. But I think to be scientific, we have to examine that possibility. And again, that's where the control arms are really important for this as we take a look. Part of the issue with control arms is you can't always mandate a specific sequence, which is really our question, is combination versus sequential meaningful? There was some data on subsequent therapies in IMvigor130 that was collected. Hopefully we'll see that summarized.